So somebody wanted to know about the difference between apraclonidine versus cocaine and also hydroxyamphetamine in the evaluation of the Horner syndrome. And the question is, what happens to the smaller pupil and what happens to the bigger pupil in anisocoria from the Horner syndrome? So as a reminder, when you have the Horner syndrome, you have anisocoria. One pupil is bigger and one is smaller. Because it's a defect in the sympathetic nervous system, it's the smaller pupil, the myotic pupil, that's the problem because it doesn't want to dilate, and it'll demonstrate a lag in dilation, which means when you turn the lights off, it'll dilate slower than the normal pupil dilating. So the combination of anisocoria greater in the dark plus the dilation lag is the clinical evidence of the Horners. And because the sympathetics also innervate the upper lid Mueller muscle, 1 millimeter ptosis and an upside down ptosis from the equivalent unnamed muscle in the lower lid. So ptosis, upside down ptosis, meiosis, dilation lag, these are the features clinically of the Horners. And so now we're going to use the drops, apraclonidine and cocaine, to confirm if this is a Horner syndrome. But as a caveat, in the acute setting, acute Horners with pain, don't do the drops. Just scan the entire axis from hypothalamus all the way down to thoracic T2 in the chest. In the ER, CT, CTA, and in the outpatient center, MRI, MRA, head and neck, down to thoracic T2. Back to apraclonidine now. So if we put in apraclonidine into an eye, apraclonidine is an alpha. It's a sympathetic adrenergic agent. And as you know, there are two receptors, alpha 1 and alpha 2. Under normal conditions, the alpha 2 effect predominates. And as you remember, the alpha 2 is the presynaptic alpha, and the postsynaptic is alpha 1, and so there's negative feedback here to turn off the sympathetics. So if you have alpha 1 activity, that is going to be sympathomimetic activation, but you have alpha 2, that's actually antagonistic. It's to turn off the system. So under normal conditions, if you put apraclonidine into someone's eye, it actually makes the pupil slightly smaller, even though it's a sympathomimetic, and so that's counterintuitive, but it's because it's predominantly alpha 2. However, if you denervate the sympathetic nervous system, you'll get upregulation of the postsynaptic receptors, which will upregulate alpha 1, which means apraclonidine now will cause dilation of a pupil that didn't dilate before when it was normal. And so what it causes is a reversal of the anisocoria. The small pupil gets bigger and the bigger pupil gets smaller, but the endpoint is the myotic pupil gets slightly larger. It'll also reverse the ptosis and the upside down ptosis from the same mechanism. So apraclonidine, the endpoint is reversal of the anisocoria or dilation of the myotic pupil and reversal of the ptosis. Cocaine is also a sympathomimetic, but it's not a direct acting sympathomimetic like apraclonidine. It is an indirect sympathomimetic. And the way cocaine works is it blocks the reuptake of norepinephrine at the junction. And so it allows more norepinephrine to appear in the junction, which will dilate your pupil. So a normal pupil will dilate in response to cocaine. However, if it's been denervated, when you put the cocaine in the eye, the little pupil won't dilate as much because it doesn't have any norepinephrine to begin with, and therefore inhibiting the reuptake of the norepinephrine will make no difference on the smaller pupil. So the endpoint in the cocaine test is post-cocaine anisocoria greater than a millimeter. So if we still have 1 millimeter or more of anisocoria after we put in the cocaine test, then we know that we have a possibility of a pharmacologically confirmed Horner syndrome. So it's not the same effect as apraclonidine. Apraclonidine makes the little pupil dilate. In cocaine, the little pupil doesn't dilate, either not at all or less than the normal pupil. And that is how you interpret these two tests, apraclonidine and cocaine, in the Horner syndrome.